All right, everyone. So what we're going to do is we're going to do a full code, which means we're going to integrate your EMT knowledge on top of and layered in between the AHA framework that you learned for heart code. So we're going to expand your algorithm to kind of build everything in together. And it's important to recognize that when you are in a EMS setting, you're going to be working with firefighters and police and paramedics and other EMTs, and so a lot of things happen at the same time, which makes the algorithm shrink a little bit. But what we're going to do when we test you and quiz your knowledge on how to run code, we're going to do it very systematically through an algorithm, one thing at a time, systematically, so that we know that you know what to expect and how to walk through a code. So how we're going to do that is I'm going to be assisted by some invisible people and Liz, and Lynn is going to give us a dispatch and walk from start to finish. So Liz is over there, but Lynn, what is my dispatch?
Okay, you are dispatched to the mezzanine at the Dean Smith Center near one of the food courts for a man down.
Oh Lord, okay. Scene safe.
Scene is safe.
I have my PPE on. I am thinking about number of patients. I have one patient. Additional resources, I'm going to want security on scene, maybe law enforcement, probably fire department, and I'll keep ALS in the back of my mind. Nature of illness, it could be a broad differential. I'm going to keep altered mental status, cardiac, respiratory, could be allergic, could be hypoglycemic, sure. Keep a broad thing. I'm going to worry about C-spine as well.
No C-spine needed.
Okay, great. And that is everything I needed to do. All right, so what is my general impression?
Your general impression as you walk up is a patient lying on the ground, not moving.
Oh my, okay, so I'll tap and shout, hey, are you okay?
No response.
I'm going to activate my additional emergency response system. I am EMS, but I'm going to call ALS because I'm worried about this person, so ALS is on the way. I'm going to check for breathing and a pulse at the same time.
Not breathing, no pulse.
I'm going to begin compressions. 1, 2, 3, 4 at a rate of 100 to 120 with a depth of at least 2 inches or 5 centimeters. And I'm calling for additional resources and other EMTs and firefighters to help me with this code.
Okay, assistance has arrived.
Great. Continue compressions. Go. I'm going to now go to airway and breathing at the same time. My partner is counting out loud. I'm remaining calm.
2, 3, 4, 5, 6, 7, 8, 9, 30.
1, 2. Those first 2 breaths were without an adjunct, but I think I did okay with my head tilt, chin lift. But I'm going to do a good measurement of tip, corner of the mouth, ankle of jaw. I'm going to hurry up because she's getting ready. There we go. 1, 2. Those both went in. This is hooked up to emergency oxygen at 15 to 25 liters per minute. It's great. And we're just going to continue 32. Remember, push hard and fast.
Your AED has arrived.
My AED has arrived. Just, all right, I have another partner. Do I have another partner doing
Yes, you do.
Breathing? Great. Ow. The first step of an AED is always to turn it on.
7, 8, 9, 30.
2 breaths. 1, 2.
To patient's bare chest.
I'm going to get my connectors all buttered up. Bottom left, on the chest wall, not the abdomen.
7, 8, 9, 30.
Top right. Make sure I do this correctly. Analyzing, stand clear. Are you clear?
Clear.
I'm
Do
clear
not
too.
touch the patient. Shock
A
advised.
shock is advised. If you will do compressions while it charges, you're on it, so I love
Stay
it.
clear of patient.
I'm about to deliver a shock.
Deliver shock.
Delivery shock, everyone's clear. Shock delivered. Go right back into compressions. Actually, if you will rotate with my invisible person at the head and do compressions, that person is now doing 30 to 2. And now would be a good time to do a king airway. I think I have some time to do that. So although Liz is at the head, I'm going to do the king because I want all the glory. So I'm going to get everything out. I'm going to test it, lube it up. So we're doing 30 to 2. This person is, let's say, 5.5 feet. This is still sterile. So it's lubed up. I tested it. All right, Liz, if you'll scoot aside as I put in this advanced airway.
And if you have capnometry available, you
yeah, I
want
would
to
love
attach
to do
that.
that. So my breather, my ventilator now is now going to do continuous compressions, one breath every 6 seconds, if you will, with continuous compressions. And I'm additionally going to confirm placement. I have a capnometer on. It looks like it's flashing yellow, which I'm enthusiastic about. Squeeze.
You hear good bilateral breath sounds, nothing over the
Bilateral
epigastric area.
breath sounds. Excellent. So I've established an advanced airway. We are doing continuous compressions with breaths every 6 seconds. My AED, we are ahead of the curve. We'll just wait until it goes again. But maybe what I can do is I can cycle in myself to do compressions, so that person can come out and then they'll come back in after the AED. 1, 2, 3, 4, 5, 6, 7, 8.
Analyzing heart rate.
Analyzing, staying clear.
Do not touch the patient. Shock advised.
Shock is advised.
Charging. Stay clear of
Stay
patient.
clear. Are you clear?
Clear.
I'm clear as well.
Deliver shock.
Shock is delivered. Go back in.
Delivered.
My other person is doing continuous compressions.
If needed.
Now what I can consider,
CPR.
I'll just make you a little quieter. Now what I'm going to consider is my secondary assessment. So I want to do a physical and get some vital signs and do a sample history. So I'm going to start with my physical exam. So I'm going to walk through the top. I'm going to do decap ATLS on the head. Look at the pupils. Do I have
Pupils are fixed and dilated.
fixed and dilated? Well darn.
No injuries to the head.
All right. Anything coming out of the nose or the mouth or the ears?
No,
Is my trachea midline any JVD?
no,
Anything on the back of the neck?
no.
All right. Do I feel stable clavicles?
You do?
I'm working around the person doing compressions, but do I feel any unequal chest rise with ventilation?
No.
I'm going to do a palpated abdomen.
Fine.
Fine. Pelvis is stable.
Pelvis is stable?
Going any priapism?
No.
Hope not. Let's go down to the bottom. Do I feel pedal pulses?
No.
That's what I expect. Okay, and then cap refill on the feet.
Nothing.
All right, and then of course I'll try any sort of sensation or not.
No
Do I
reaction.
feel femoral pulses when my person is doing compressions?
You do?
Oh, excellent. Okay, that's expected. All right, that's not ROSC yet. So now we're going to do arms down, trying to work around so my partner is doing compressions.
No findings?
I look from some cyanosis over here. Do I feel radial pulses?
No.
Okay, and then probably no motor or sensory. I can't do the back yet, but I'm going to defer that till later. I'm going to do vital signs. So the only vital signs I can really do, I can't do a heart rate, can't do a blood pressure, can't do a respiratory rate. I did pupils. Skin condition generally is
Very pale and cool.
pale, cool. Okay, that's unfortunate. I don't really need a temperature. I could consider a glucose. Let me do a blood sugar check.
Blood sugar is 110.
110. So I did a physical. I did whatever vitals I can get. I can do a pulse ox. I should do a pulse ox actually.
Pulse oximetry is 98% with good ventilation.
Everyone's staying clear.
Do not touch the patient.
Is anyone nearby to do a sample?
Yes.
Tell them to wait a second.
Shock advised.
Shock is advised.
Charging. Stay clear of patient.
Clear. You clear?
Deliver shock.
Shocking.
Shock,
Shock delivered. Actually, if you can do compression, so that person can now do continuous
Begin
ventilation.
CPR.
So we can rotate every 2 minutes. All right, sample. I want to get some signs or symptoms that this patient was expressing before they collapsed.
So the gentleman was standing in line, and all of a sudden he clutched his chest and he said, "I don't feel so good," and then he collapsed. Somebody helped him to the ground.
Okay, so on my differential, things that have moved up are cardiac and respiratory in nature, less so stroke or diabetes, also with the blood sugar. So that's signs, symptoms. I can't do OPQRST because he can't tell me anything. SA, who is this person relative to this patient?
I'm his wife.
The wife. Okay, does the wife know of any allergies this patient has?
He has no allergies.
Does he take any medicine?
He takes medicine for hypertension. He's on warfarin. He takes an aspirin every day, and he has coronary artery disease.
So I recognize the warfarin and the aspirin are blood thinners, antiplatelets from his coronary artery disease. So coronary syndrome raises really high on my differential, SAM, P, you told me the pertinent history and the meds. Last thing he ate?
We were just going to get some snacks tonight while watching the ball game, so he hasn't eaten in a couple of hours.
I want to provide empathetic communication to the wife about the series of unfortunate circumstances, and then he told me the events leading up. He clutched his chest. So I'm going to recheck with ALS if they are en route.
They are.
Okay. And to summarize with all my team members, because I'm the leader, we have someone who clutched their chest with high coronary risk factors. We've established compressions continuously. We've established an advanced airway with continuous compressions and a BVM with supplemental oxygen. He was euglycemic and has normal oxygen content in his blood. We have shocked 3 times for a total of CPR of about 7 minutes. ALS is on the way. We're just going to continue our algorithm in the CAB sequence. Analyzing heart rhythm, stand clear.
Do not touch the patient. No shock advised.
No shock advised. Go back on the compressions if you will.
If needed, begin CPR.
Can any of my team members think of if I'm missing anything?
Nothing that I can think of.
I appreciate your feedback.
So 2 minutes have gone by. You
Okay.
get another no shock advised.
Another no shock advised. So I know the AHA says no ROSC check, no pulse check, but in EMS we can consider it after 2 no shock advised. So pause compressions. Do I feel a pulse?
You do.
All right, I want your finger on the femoral pulse. I'm going to recheck a whole primary. Hey, are you okay?
No response.
All right. Is there any ventilatory movement on their patient's own?
No.
All right, I'm going to tell my breather to do 1 breath every 6 seconds. We're still doing supplemental oxygenation. My airway's still patent. I'm going to, what's their heart rate?
Heart rate is 70.
70. I'm going to auscultate lung sounds.
Equal and clear bilaterally.
And then I'm going to do a manual blood pressure.
Blood pressure is 80/62.
80/62. I have a finger on the pulse. I'm going to look at their eyes and their skin condition again.
Pupils are sluggishly reactive.
Skin, any improvement?
Skin is pinking up.
And we had a respiratory rate of 0. So I have repeated vitals. I did my full primary assessment. I want to transport this patient to the nearest hospital.
How are you going to transport your patient?
Because they could rearrest, which is a high likelihood, I'm going to put this patient on a backboard so that way we have a firm surface on the way to the hospital. So I'll put them on a backboard, and on the way to the hospital, I'm going to turn off the AED and keep the pads on in case the patient rearrests, because I don't want to take the pads off. And then we can continuously monitor this patient's pulse. We're going to reassess them every 5 minutes, another primary. We're going to do vital signs every 5 minutes, and then check our interventions, make sure our airway is still intact, and make sure the patient's hemodynamic status is improving.
So you're going down the road en route to the hospital in the ambulance, and you recognize that your patient no longer has a pulse.
Oh my! So I'm going to immediately tell the driver of the ambulance to pull over and confirm we have no pulse. But then we're going to also begin CPR, and I'm going to return on my AED.
Analyzing heart rhythm.
And analyzing, if you
Do
would say
not
clear.
touch the patient. Shock advised.
Shock advised. Charging, if you will do compressions.
Charging. Stay clear of patient.
Clear.
Clear.
Deliver shock.
Shock delivered.
Shock delivered.
I'm going to notify the hospital that we had to defer transport to them because of a rearrest, and then hopefully ALS is getting their butts in gear, because this has been a BLS show, and it would really not be nice to have some paramedics on scene.
All right, good job. You can end the scenario.
Scenario is in.